Well, good afternoon, everyone. I make it 2 o'clock according to my timing. Lovely to see members of the public joining us. We've had a busy morning already with the board workshop where we've looked at the progress each of our divisions are making on world-led activity. We had a discussion on our staff survey results, which we'll touch on today. And we also had a patient story from a carer about the experience they'd had accessing the services of the trust. And I am aware that a body of work is going on, which Natalie and colleagues are leading on to try and improve our services for carers with loved ones who have Alzheimer's and dementia. So I do want to assure members of the public that that work is ongoing to improve the experience during what I know would be a very worrying time. We've got a full board today, so looking forward to getting on with it. So we have apologies from our Managing Director, Catherine Free. So Robin is kindly deputising, and our Deputy Chairman, Julie Holder. Are there any other apologies for absence, Sarah?
I think from Rosie, I know she was away at the moment and having network connection issues. So from Rosie as well, please, Russell.
Okay, great. And I assume Umar will join us in a moment. Any new declarations of interest? Please raise a digital hand. Okay, so minutes of the last meeting held on the 7th of March. I wasn't there, but if there were any points of accuracy, could you please raise a digital hand? Okay, I can't see any digital hands being raised, so I will take those as an accurate record. So we'll go then to page 19 of our pack, to the action points arising. And the first was for Natalie to check whether friends and frailty test data for breast outpatients could be obtained to ascertain if there are any concerns raised in respect of the patient experience. Natalie, do you just want to brief us on this?
Yes, we can obtain directorate and area specific information from the friends and family, and we can have a look specifically at any comments that are being raised. So what I've asked the patient experience team to do is to do a look back over the last 6 months to see if there's anything of particular concern. For our immediate look, there has been nothing, but I just wanted to make sure and get that double check.
Super, thank you very much, Natalie. So please keep us briefed. And similarly on keeping us briefed was the next point, which was a full-time equivalent productivity per head measure. You're coming back to that hack, I think, in June, so thank you. And also the final version of the submitted 23-24 plans. We are talking about them a bit later today, but they will be obviously ratified in due course. And then we have from a while ago now, Jenny to provide the board with an update once the sustainability surveys had been undertaken. Now, I think this goes back to issues raised by Councillor Caldicott on the issue in particular of whether we can use the trust estate more effectively with solar panels and wind power. Jenny, we've got complete on this. But where are we on those two particular issues? Because I think that was the original point that was raised.
Yeah, so we've undertaken a significant amount of work in terms of reviewing the opportunities and the options, and we've developed a set of initial proposals which we've discussed with our executive team, and that will form the basis of our bid for the next round of opportunities, which has just opened in towards the end of April. So we are just finalising those plans and opportunities to look at the requirements in terms of any investments, etc. But they are being developed, and solar panels is a key feature within those propositions and proposals, alongside a number of other smaller initiatives which would support the effective sort of sustainable focus across the estate.
Great, thank you, Jenny. So are there any matters arising that I've missed? Please raise a digital hand. Now, for many of us, the highlight of the month is Glenn Burley's Chief Executive report. So we'll move on at a canter to that. Glenn, how are you seeing things?
Thank you, Chairman. Yes, so the first part of my report actually follows on from what I reported last time, which is the National Urgent Emergency Care Strategy, and includes what is currently my favourite chart, which is analysis of. This one happens to be Warwick Hospital, but actually the data would be the same for George Eliot, it'd be the same for Hereford County Hospital in Wye Valley, and shows the average age of patients in on average over Q2 of 22-23. And what it shows you is the majority of activity that goes on in a district general hospital like ours is brought about through frail older people admitted as emergencies. And so you can see that demographic of and source of admission. And it helps to highlight how there's a changing pattern of activity, and also highlights the fact that crude length of stay now is not a really good indicator. So what we're trying to do across the group is look at better ways of managing urgent emergency care, because a lot of the very short stay activity that we used to see in inpatient beds is now transferred into same day emergency care. And we've been really good at that at George Eliot. And then there's a middle group of patients who are within the hospital itself, where their length of stay is determined on things like diagnostic processes, ward processes. And then there's a longer stay cohort who are some of those patients that are maybe not benefiting from rapid flows of discharge out of hospital. So starting to look at it in those three cohorts starts to give us an idea about how we can make improvements to it, and we'll be tracking some of those improvements later on, and I'll come back to one point in a moment. So that's something that we will continue to be focused on. The Integration Frontrunner programme is looking at that longer stay cohort of patients, and we were really lucky that we put forward a proposal to be part of this national programme for a piece of work across Warwickshire, which will look at how we can improve our discharge to assess pathway one, which is those patients who are going home rather than going into an NHS-funded care home bed. And so you can see within the content of that update, the work that's going on in this piece, led by Becky Hale, who's the joint post between Swift and Warwickshire County Council, which is a really exciting piece of work, which will be getting the national attention, which will help us to build some solutions to ensuring that that longer stay cohort get home as quickly as possible. And within that, we'll be looking at the prospect of whether we can directly deliver some domiciliary care by the NHS through our partners at Swift. Then I refer to the National Staff Survey. Now, we spent, as you said, Chairman, a bit of time this morning looking through the detail of that. And the chart that's included on page 5 of my report shows the people promise themes and where we performed compared to the other parts of our sector. And the chart also shows the best and worst performers. And as I've commented, we come over as a bit average, which is not what I would want for George Eliot. So we spent some time this morning talking about this. We also got it under the bonnet of the report, and we'll look at this later on in the agenda also. And so what I would want us to do is focus in on some of the messages that are coming back from our workforce. I want us to be an organisation that attracts and retains people, and where all of our people feel that they can meet their full potential, and where it's they feel safe to raise concerns if there are concerns about safety, and where they know that they're going to be tackled. So it's such an important indicator that over the course of this year, you'll see a lot of focus in the boardroom and across the organisation about how we get ourselves up into the best performing, because that's where we can be, in my view, and ought to be. I refer to NHSE headcount reduction, which is obviously a disruptive thing at the moment for many of our colleagues in NHS England. But this comes down to also the opportunity for us as we move forward as lead provider at place for us to take on some of that capacity and capability. So as part of our place-based leadership discussions, we'll be looking to see whether there are people that can join us as we take on that commissioning role, to ensure that we retain their skills moving forward. I then refer to the junior doctor strikes that took place last month. Sadly, we're now looking again at another series of industrial action, which is most concerning for us all, which will be between the 11th and the 15th of April, so 4 days, immediately following a 4-day bank holiday, and then obviously going into another weekend. So that's a lot of days of not having full capacity from our medical workforce. During the last industrial action, our consultants, our senior clinicians, our managers worked really hard to ensure that everyone was kept safe, and obviously we'll be doing that again this time. But it becomes harder to do over a longer period of time, particularly after a bank holiday. And one of the issues for me actually is what we should be doing right now is looking forward and dealing with backlogs rather than trying to tackle such a big pressure on a day-to-day basis. There are no derogations for that strike action, so we will literally be without all of our junior doctors. And I think when we say junior doctors, that covers basically everyone who isn't a consultant. So some very experienced doctors. So that's something that we'll have to keep a really close eye on, and credit to the operational teams who are managing the preparation for that, and will manage the incident itself. I won't go through everything else in the report other than to point to the fact that we've got a directorate update from Clinical Support Services. This morning, we heard from all of our directorates on their approach to well-led, if they were inspected by the CQC, and it was great to see such a large amount of activity and progress across the organisation. I think one of the challenges that we reflected on this morning was the need to summarise that and think about what the big priority issues are, which we will do a little bit later on in the agenda when we look at our objectives for the year. And there's also then an update from the health and wellbeing team and the normal list of executive and non-executive visits to departments. So I'm happy to take any questions, Chair.
That's great, thank you, Glenn. And I'd just like to put on record my thanks to all of our consultants who during the last junior doctor strike, and I'm sure during the next one, will be as flexible as possible to try and look after the patients and the citizens we serve. Any questions or perspectives to Glenn? I guess your greatest worry then, Glenn, at the moment is the junior doctor strike and what that does to capacity, because as you said, junior doctors are about 40% of our capacity. Would that be correct?
Yeah, it's not just capacity, actually, morale. Because you know, the impact over those 4 days is one part of this, but the impact on the entire workforce of having to manage this, but also on the junior doctors themselves, because you know, they want to be looking after patients. So the sooner we get to a resolution, the better. But we do need a resolution.
Well said. Thank you, Glenn. Okay, colleagues, if there are no points to Glenn, we'll move on to the Trust and Foundation Group annual objectives. Glenn and Jenny?
Yeah, so I'll kick this off and Jenny will sweep up after. So I deliberately chose my background today just to help to bring to life the strategic refresh that we've just gone through as a group, as an organisation. So we went through this when we last met with the 3 boards together across the foundation group, and it was great following the work last summer that each individual board did, that we actually found a huge amount of common ground in terms of that strategic direction. So our updated strategy has a number of strategic pillars, which you can see around the outside of me, and a number of big moves. So 5 big moves that we've identified. And these are things that we're going to spend a bit more time on as an organisation in order to ensure that we make more rapid progress towards implementing our strategy. And so the documents that we produced in all 3 organisations have been very well received by the staff, obviously co-produced them, as did our partners, and it's helped to crystallise the things that we think are important. All of which then sets a framework through which we can look at our annual objectives for the coming year. And these were looked at in draft form in our private meeting last month and come into our public meeting today. And what Jenny's done in typical Jenny style is tracked all of those through to both the pillars and the big moves. So you can see within the document we've identified a number of really important things that we're going to do over the course of the year. And once these are signed off formally by the board, they will then be underpinned by the board assurance framework. They're already captured in objectives for the executive team, including some of the actions on the staff survey, and that will cascade through the organisation. So, Jenny, is there any nuances you wanted to add to that?
No, other than to just say that we've already started the process of the conversations with our management teams through our Leading with Purpose arrangements, which is the cascade process. So we're well positioned once these are signed off to cascade through PDRs and through teams, etc. And we have that process ready to go. So that was the only thing I would add.
Thank you, Jenny. Thank you, Glenn. Any questions? We've obviously, as a board, seen this a number of times before, but any questions from colleagues? Okay, so I think this is for approval, isn't it, Glenn? Okay, so if you're not happy to approve, could you please raise a digital hand? So duly approved, thank you, and thank you for all the hard work. I would just ask for one thing as an objective this year for my executive colleagues. Now, today's board pack is 411 pages. That is incredibly burdensome on both yourself and your teams to produce these big board packs. I want to set you as an executive team the objective of never having a board pack more than 200 pages in any month. You can put stuff into the appendices, but I want to start to reduce the burden on your executive teams in just producing paper and feeding the machine. My counsel to all executive directors would be, when you do your executive summaries, go on for no more than 2 pages. So I give you that challenge, but the macro challenge, and Robin, if you can feed it back to Catherine, I'm going to say exactly the same thing at Swift and Wye Valley, is to get the public board papers to under 200 pages going forwards. I want to reduce the workload of the board onto the executive directors so you can focus on delivery of these important objectives. I'll leave it with you.
Well done, thanks, Russell.
So we then move on to the sustainability quarterly update, and Jenny, back with you.
Yes, thank you. And I am joined with colleagues that have been that contributed to this paper. So Susie, Kirsty and Sean as well, just to note the work that's been going on behind the scenes. Obviously, I'll take the paper as read, but there are 3 things I'd like to just really pull out really. This is our quarterly update, as you said, and it basically focuses on the delivery achieved against our green plan primarily across those 9 focus areas. And as I think you can see from the report, that we're making good progress in those deliverables, and we've given you a flavour in each of the 9 focus areas of some of the specific work that's been undertaken, just to give you a flavour behind saying that there's X number of deliverables being achieved. In the appendix, we've got the status of where we are on the deliverables. The other thing I'd like to point out, 2 things to celebrate, I think particularly. One is, this might be a small initiative, but I think it's a really a significant initiative, is that we've got the development of the garden development, which I think will be really nice for people coming onto the site. And it's another thing that sort of impacts in relation to sort of staff wellbeing, etc. And just to note, if people are wondering at certain points if it just looks like a bit of a wilderness, that it will take shape and it will be our wilderness garden. And the fabulous thing about this is it's been done in collaboration with some of our communities, and particularly some of our local schools, etc., which I think is something to really celebrate and to build on. So that's why I wanted to draw your attention to that particular initiative. Secondly, I'd like to join initiative to the fabulous work that some of our champions have started to do. When we last reported in our last reporting period, we only had 2 sustainability champions. We've now got 14, and that's fabulous in itself. And I think the other thing to note is that they're across such a wide variety of areas within the trust, as you'll see within the paper. So I particularly would like to celebrate that. Finally, the thing that I would like to pull out is all the communications work that's been going on, which is really about trying to ensure that we embed sustainability and kind of generate a passion for sustainability. And you'll see there with the infographics of the work that's happened to support and achieve that. And I think that is really driving that collaboration then across the focus areas in terms of the work that's been undertaken across the whole of the trust. So in totality, I feel that we've made significant progress in a number of the areas, particularly in terms of delivering on the focus areas, and we've got really good compliance in terms of our reporting. So we've got really strong assurance of the programme of work that's been delivered. Finally, and just while I've got Kirsty and Sean with me in case there's any questions to this, is we've also really taken forward the decarbonisation plan programme of work, which links in with our green plan, which was a requirement for each trust to have in place by the end of this month. And I can give assurance that that is also in place and is also part of the foundations for us being able to apply for funding for our PSDS, and I think I've got the acronym right, in terms of the work that we mentioned before about potentially being able to take forward some of our exciting plans around things like solar and EV charging. So I'll stop there. Happy to take any questions, and just thank you to the teams that sit behind all of this work. It's quite broad. Thank you.
Thank you, Jenny, and you know, Kirsty, Sean, Suzanne, others. You've done a great piece of work. Is there anything you'd like to add to what Jenny said? Are you happy to go to questions? Okay, so questions and perspectives. Glenn?
Yeah, it's great to see the update. I think we've set the bar quite high on this area, because within our big moves, we've said we want to lead the NHS on carbon reduction. So there's the challenge team. I suppose a question for me on this will be, we've got ourselves ready to make a bid for the decarbonisation funding. When's the next opportunity for us to bid? When do we expect to submit something?
So it's literally just come about, and we believe, I think it's the 28th of April. It's open from, but I was just, but Kirsty's shaking her head, so I'm going to go to her.
There's the low skills fund, which is the end of this month, and then the PSDS funding next round is sort of the autumn, September, October time when that's due to open. So we'll be ready for them.
Okay, thank you, Kirsty. And Natalie?
Was just a comment on the increase in the number of champions. Whenever you talk to staff and you go out and about, they are very, very passionate about sustainability and the green agenda and have lots of ideas. So that's really great to see that we're now increasing our champions.
Yeah, fantastic. I mean, it's something to be really proud of. And finally, Sarah, and then we'll move on.
Yeah, just a quick comment, really. I think this just looks like a really positive piece of work. You can see how you've drawn it from that really macro big pieces of work through to people being involved in their individual lives as well. And I think that will make sure that it's sustainable and something that everyone can get involved in. I speak every so often to the non-executive director, who's the regional lead for green and sustainability, Joan, and I have to say that these type of plans and knowing that this work is going on, it makes me really proud. And we are sort of, I know it's a big task, Glenn, to be at the front of leading the NHS on this, but I think regionally what I see here is hugely positive. So just credit to the team.
Yeah, really great work. I'd just like, Anil is chairman of the charity. I, for my sins, plant 1,000 trees every year. People don't know that, but I do. But Anil, I'd just like to give you the thought that the charity might want to support that for every person who dies in our care and for every baby born in our care, we plant a tree every year. Okay, can I just ask the charity to have a think about that? It would link in with our green plan, but also I think would very nicely link in with what we're about as a charity and be able to celebrate babies born and people we've said goodbye to whilst in our care. I'll leave that with you as chairman of the charity. Okay, team, we'll move on to the report on nursing and midwifery staffing. Natalie, over to you.
Thank you, Chair. And taking the report as read, the areas that I'd just like to bring to the board's attention this month that despite the daily staffing gaps that we have and the multiple moves that are made, we are able to verify through the reduction in our red flag incidents that there have been no moderate harm or any above related to staffing. So I think that's really testament to our staff, making sure that they're looking out for that safety element each and every day and each and every shift. Our prime focus is recruitment and retention across the organisation, and I think we all know we're very heavily involved within that. That being said, obviously we also recognise that the vacancy variances does have a negative effect on many areas such as staff morale, the staff survey, and also a financial burden due to the temporary staffing usage. I'm glad to say and happy to highlight that actually we have been able to reduce our overall vacancy rate by 4% from last month, and we have just recently had another recruitment event for healthcare support workers, which we made 18 offers to staff, and also for registered nurses where we made 7 offers. So we're slowly chipping away at our vacancy rate, and we will continue to do this, and we have another 10 international nurses joining us next week. In section 3, you'll note that we've done a very detailed section with regards to the operational pressures, the extra capacity that's open, and what that means to our staffing usage, the number of moves that we have to do on a daily basis for our staff to cover across the organisation, and also the impact that this has financially because of the extra hours that we put out to temporary staffing. With regards to the recruitment and retention, hopefully this will then bring this down, and the successes of us being able to close our extra capacity will mean that we won't be doing as many moves and hopefully reducing the financial burden. And usually, and for my report, we have reported one occasion where we did not achieve the one-to-one care for women in labour for a very short period of time, and I'm sure Lorraine would be able to expand on that. We do and still continue to be above the national target, which is 90%. We achieved the 99%, but usually we have 100% all of the time. So this was very short incident of only 20 minutes, and then we were able to mobilise our teams and be able to call upon the community midwives as well to be able to get that one-to-one care back in place. But no harm came about, and everything was done very quickly in an organised manner. So I'm happy to take any questions on the rest of the report or anything I've said, Chair.
Natalie, very comprehensive and assuring. Thank you. Any questions or perspectives to Natalie? Great to see the recruitment coming through, and that really speaks oceans to colleagues feeling as though George Eliot is a place they want to work for. Then we need to make sure once they're with us that they love being with us, and that goes back to Glenn's comments about the staff survey, us not wanting to be average. Colleagues, happy to move on then to the maternity assurance update, and I guess Natalie, Lorraine will be leading on this. So Lorraine, over to you.
Thank you, Chair. So I'm going to take the report as read and just pick out a few highlights. So this is data from February 2023. So in month, we didn't have any neonatal deaths, stillbirths, maternal deaths or SIs. Our stillbirth rate still is way below the national average of 4.2, so we're running at 2.29 rolling per month, 12-month period, and we're monitoring that very closely. But that's really reassuring to see, really pleasing to see. But I have to give a caveat: our midwife to birth ratio was 1:21 in month, but it was February, so it's 3 days short. But actually, when we looked at the data, our thickness rates were way below the trust target, so that really helped. But we were 30 births down on the previous month. And when we look back to our bookings in April 22, we could see that actually we were 30 women short as well. It wasn't that people had not decided to birth with us. It was just actually our bookings were down in months, so that tallies. So, but really still really is good to see. And that coincides with our really good vacancy rate. So we're below 4% there, rolling recruitment and trajectory, which is really great. Staff want to come and work here. We don't sit on our laurels, though. We are making sure that we're continually retaining our staff and giving opportunities, listening to our staff. Also pleasing to see that we have improved our compliance with Save My Baby's Life version 2. So we submitted our data back in January and got confirmation in February that actually we were now compliant in 2 aspects of compliance, and we had actually gone from 53 to 77% in month from August to February, which is really pleasing to see. Again, we're just due to submit that, and we know that version 3 will be due to be submitted soon. We also in February submitted our CNST data, and we can see that we achieved finally 6 out of 10. We know that actually if we looked at our data now, we probably would be almost fully compliant, but obviously we missed out on some areas around training. But we are making sure that we've got a really good trajectory for that, and we're awaiting release of year 5 for CNST, continue to monitor Ockenden, and just to say the single delivery plan came out last week, so we'll be working to look at the recommendations and the objectives that have combined the East Kent report and Ockenden in that. Really pleasing to say that our theatre refurbishment has commenced, so that commenced in March, so really good to see, and working really closely with our colleagues in main theatres who are going to be taking over staffing of main theatres for us as well. And we also have planning to move, although we have moved it, but obviously this is February's, but planning to move triage down to our main delivery suite because it's combined presently before with MAU. So as of Monday, we've moved that down as well. So lots of change going on in maternity, really good progress in month, but obviously we just need to continue to monitor that very closely. Happy to take any questions.
Thank you, Lorraine. And I know it's a crude measure, but the stillbirth rate number is really pleasing because the catastrophic impact a stillbirth has on everyone involved. Questions and perspectives to Lorraine? Natalie?
Just a perspective really, and a congratulations to the leadership team within maternity for pulling those elements that Lorraine described around and increasing our compliance. Having that vacancy rate shouldn't be underestimated. It is not the national picture, and with actually having staff want to come and join us and queuing up to join us, that's just brilliant and something that we would want to emulate across the whole of the organisation.
Absolutely well said, Natalie, and a good point for us to segue into the maternity inpatient survey results report. So back with you, Lorraine.
It is, thank you. So again, I'm going to take the slides of red. So it was really pleasing to see that our compliance had moved up and we're now in the top 30 feedback from our women who use our services, which was really pleasing to see from the previous year. I just need to give the caveat that these are women that birthed their babies in February 2022. So actually a lot of their care would have been through 21 when COVID. So actually some of those feedback around family and partners not being able to visit or being in caring is because obviously the restrictions that we had in COVID. So they've all been released, and we've got Mum Plus One and things all back in place now. So that'll be really reassuring to see. Obviously, we need to work on making sure that we're getting more women to complete the survey, and we can see that actually there were more women who had birth before with us that fill that in. So actually, we need to make sure that we are targeting all women, even if it's their first baby. It was really good to see that actually we didn't have any negative areas of improvement, and actually it was we were at 6 areas where we were better than previous. Again, we're not going to sit on our laurels, but there was some really good positive feedback, and we're doing lots of work with our MVP around the induction of labour process, because that was another area that they picked up there. So overall, a really good position to have seen progress in, but lots of work to continue to make sure we maintain that. Happy to take any questions.
Super, thank you, Lorraine. Very pleasing. Questions and perspectives, Simone?
Thank you. Really encouraging to see this, Lorraine. Shows how the hard work is paying off, notwithstanding that it's from a while ago. A couple of the lower scores relate to comments about GPs, and I just wonder how that gets fed back to the GPs. How do they know about this?
Yeah, so across the system, we've got some really good working with our GPs. I think that was fragmented and stalled a little bit during COVID because obviously we took our clinics out of GP surgeries and we're doing postnatal clinics or not doing visits, we're doing virtual visits and things. So it's about re-embedding those relationships and so we have shared the survey across our community so that they're aware of that, and our community midwives are linking back up with our GPs so that we've got a bit more system working. I think we've still got a little bit more improvement to do that to get that back. I think some GP surgeries didn't want maternity back in the building, so we've still got a little bit of work to do there. But I think it's really important that we make sure that it actually goes from preconception through to when after when they've been discharged into the health visitor, that actually the GPs are involved and we're involved in that care. So just need to reconnect a little bit, but it's pleasing to see.
Thank you.
Thanks, Mon and Glenn.
Yeah, it's great to see the survey results. Very much concentrate on the mother, but one thing I remember vividly from a previous workshop here was the experience of a father. Are we still engaging with partners as part of our feedback also?
Yeah, absolutely. And we've set up a dad-only group. Although that will be open to any partners as well, but I think there was a focus particularly around the dads first because we've got one of our champions, his partners, runs the dads charity, so we wanted to make sure that we worked with him, but also we'll open that up to all partners. So that's opened up, and we're doing back face-to-face antenatal classes back in the community. So we're going out into the community to support that. But the dads only group are really loving that actually they get a bit of time for them, and it is focused on their needs as well, and that really came out loud and clear in the survey.
Yeah, I think I'm still correct in saying that one of the highest causes of male suicide is in the year after the birth of their first child. So it is important.
Yeah,
I was on a maternity ward 2 weeks ago and congratulated an older father on the birth of his child, and you could see he looked absolutely shattered. If he looked shattered, I hate to think how his poor wife was, but well, for those of us who are blessed enough to have children, we all know the stresses and strains in those early days and weeks. Really great work, Lorraine. Keep it up. Please pass on our thanks to all of your colleagues.
Thank you.
And let's keep that stillbirth rate in particular well below the national average, which we know is on international comparisons too high. Now we move on then to the review of winter plans and the learning points for our operational resilience. Robin?
Yeah, thank you, Chair. So you'll see that there is a paper and a presentation attached. I'm not going to plan on talking through the presentation point by point, but merely to provide the board with assurance of the detailed work that went into our resilient winter plans for this year and how they influence next year's winter plan. So we started off from the key principles of better use of our resources, reducing admissions and length of stay, working on a home first principle and maximising our ability for staff retention. So as well as the plans around additional physical bed base, we worked on some efficiency improvements such as virtual wards and STEC that have been mentioned several times throughout the meeting and the forum this morning. And also we looked at the way in which we flexed our capacity, we flexed ED capacity, and also our escalation processes and full capacity protocols to make sure that we got all the governance arrangements, everybody was clear exactly what to do should the inevitable happen and activity increase over winter. So what actually happened, as usual, we had late notice of ICB funding, which came through in November. So obviously we'd started planning well ahead of that in anticipation. We did see a record number of ED attendances in December, as we would have expected, which then continued into early January. We suspended elective surgery late December, and we ended up opening an additional 22 super surge beds, as we called them, from the beginning of January. And Natalie has mentioned the impact on that with our staffing, morale and staffing numbers, and also the impact into the finances. The bed numbers, so just to put a sense of perspective in, our core bed base, we're funded for 305 beds. And at our peak, we had 357 beds open and 8 additional patients boarded on wards overnight. So a considerable strain on our staff and our services but all patients were maintained in a safe environment. And that was really the key success of the planning that went in. So what worked well? The teams managed the flexing up of the capacity extremely well and efficiently. The increases in SDEC and virtual wards were exactly in line with the plans that we'd set out, and everybody took the actions they needed to take. We did more 7-day working, so we looked at about how we stepped things up over weekends to ensure we've got the right services in the right places to maintain flow even over Saturdays, Sundays. We increased the support from the system partners, particularly around our Pathway 1 discharges patients to back their home residents. That worked well with community partners. And we also did a frailty assessment PDSA Cycle of Planned Use Study Act period where they demonstrated that by early intervention of frailty patients coming into ED, they could discharge 80% of them back home directly, thus reducing the need for an inpatient admission and reducing any form of decompensation for that patient, and thus hopefully impacting positively on their long-term outcomes for those patients. The charts are included in the documents, demonstrate some of the metrics we measured. We continued the reduction of medically fit for discharge numbers overall throughout the winter period. We recommenced our elective activity by the 17th of January, which was actually one of the earliest amongst most of the trusts in the region. We closed our super surge areas last month, which was again a huge benefit to reducing those pressures, as Natalie's already described. So we did what we said we would do when we worked with our teams on the escalation plans. We also had strong conversations about the de-escalation plans and having a focus with our teams, making sure that they saw that there was actually an end to winter this year, and it wasn't something that just rolled on and continued, that often happens in organisations in previous winters. So what we also saw was a reduced trend in length of stay from December and March, which again against the trends regionally, given the focus that went in with our clinical teams. And we also managed to maintain readmission rate within national averages. So we also weren't seeing patients come back in because of being discharged earlier in their pathway. So all of that was positive. So how does that impact on our planning for next winter? We've already done internal feedback sessions and review of what went well and what went not so well. We've learned from that. We've already started to formulate a plan as to what we would like to do carry forward into next winter. I've chaired a meeting with our place partners, and each of them have done a similar presentation of what went well, what didn't work so well in their winter plans. And the outputs of that, we're currently in the process of synthesising into a first draft of next year's winter plan. And I anticipate that being in a first draft format by the end of April, which I think is probably the earliest we will have seen a winter plan come together from previous years. And we will continue to push with our new models of care to be embedded. So the good work we saw around frailty pathways, changes to therapy-based models, and particular reference to links with our community partners on therapy community services and links with community response services that have been set up, as Glenn articulated in his report, and also particular attention to our initial assessment pathways for all of our specialties to ensure that patients are getting the appropriate initial assessments on presentation to ensure that we don't admit patients where they could have a better outcome from being returned home on their pathway. And the final one is obviously to reinforce our plans around ring fencing elective activity next winter, so we don't see any impact on our elective flows during that period. And I'll pause there.
Thanks, Robin. A very comprehensive briefing, and great to see the sort of active learning and agility that's being applied on this whole topic. Questions and perspectives, Glenn?
I'll definitely start with a well done, because obviously that operation ring fence approach was not only good for our elective patients, but it ensured that our emergency patients were treated in the right part of the hospital. And I know that was tricky with the surge capacity was kind of in lots of nooks and crannies across across the site, and we're looking to see how we can consolidate that into some extra capacity, ideally to reduce total bed occupancy. Within that, Robin, the modelling of the individual specialties and making sure we've got the right beds for each team, is that in your thinking at this stage?
It is, yeah, in line with that work that you just referenced, Glenn. I've got a team set up to do effectively a site reconfiguration piece of work, looking at what we've got where on the site currently and what the best fit is moving forward. And the only thing that's delayed us with that is the preparation around the junior doctor strike next week. And so the plan for that is that meeting will take place the following week, when the teams have just got that little bit more headspace to take that forward. But that's all in plan.
Thanks, Robin. And finally, Simone, then we'll move on.
It's a question really, linking back to the conversation we had about the staff survey this morning, staff experience and particularly issue of bullying. Are we paying enough attention in the lessons learned to staff experience? We've got it cast as staff availability, and we've got the wellbeing words in there, but I just wonder, are we paying enough attention to the impact on staff in the review?
Robin?
Yeah, it's a really good question, Simone. I don't think there's any doubt that obviously opening additional areas, the moves we need to make over winter period, as in any hospital, has an impact on staff. And particularly where you increase medical outliers, you've got surgical nurses. Often the way it works, surgical nurses looking after medical patients is not what they were employed to do. It's not what their specialist area of interest is. So it all has a knock-on impact on staff. I think for me, what we saw was where we were opening additional capacity, we set up the forums whereby we included the teams themselves at ground level in order to have the conversations and be part of the solution. What does that solution look like and how do we implement it? And by doing that, we found that we had a really agile approach to actually delivering the changes we needed to deliver, whilst taking the staff along with us as best as possible, and also the feedback mechanisms that we put in place to explain to staff exactly what had happened as a result of their input, and how that would influence next time. But again, there's still learning to be taken. Simone, did we get it 100% right? I don't think we did. I think we've got certainly some more learning to go.
Thank you. We're running late now, guys, but quickly, Jenny.
So all I was going to add to what Robin said was that we did also do a lessons learned piece where we actually went back out and we did got some specific feedback, and then we included that in the re-engineering piece of work that we did, and that also included going out to speak to people directly, as well as some interviews with people, and we did that across all levels. So we didn't just talk to the people that led the change, but the people that were on shift when the change happened and the people that were impacted by it, and that gave us a really good rich piece for our reflective learning.
Thanks, Jenny. So that segues quite nicely into, for members of the public, we've spent an hour this morning on the NHS staff survey results, but Gertie, do you want to just pull out any key points? And in the chat box, Robin, if you could pick up Sarah Lastrick's point, that would be helpful.
Thank you, Chair. Conscious we spent a lot of time on this morning and mindful of time, I'll take the report as read. I'll pull out just a few points and I'll start off with, as Glenn has said, is the staff survey is one of our most important indicators and certainly the clearest indicator of our staff experience and our culture. We didn't have a fantastic response rate this year, slightly better than last year, but still 33% is far below the average for our peers. And as Glenn's already pointed out, the staff survey is mapped against the 7 people promises nationally, and then staff engagement and morale. Note that as Glenn said, we're disappointed to see that George Eliot has slipped against the progress we had made last year, and that we are now round about average, which we aspire to be more than. Obviously we will work to improve that. Our staff and our patients deserve to be more than average. It does tell us that many of our staff are not having the experience we would want, and obviously we need to look at how we work that. As I've said, detail discussions this morning in the workshop, and just to pull out for members of the public, a lot of that focused on individual personal accountability, their impact, the importance of kindness and civility, and how we need to ensure that we are kind to one another, to our patients, and to their families and carers. Key themes coming out are around bullying and harassment and managers' skills, the impact of managers and how we need to support them in terms of their impact. I've noted in the report the separate reporting from the workforce race equality and the workforce disability equality. But I'm going to focus on the what is next, the what now, because this is a rich source of information, and the key ask of us is what are we going to do with it? And as Glenn's already said, it's a very focused area for us as a board and an executive team, senior leadership, and for our wider teams. And as I've noted in the report, our focus areas moving forward are listening to what our staff tell us, what they want, what they feel will change and improve their experience. A real focus on line manager skills and development, increasing the response rate. As I've said, we do need to increase that so that we've got a broader understanding of our staff experience, and to reflect and share our positive achievements and the areas of good practice we have. This isn't an area of good practice from somewhere else in the country. There are some good areas within the organisation, and we know they work. I'll leave it at that, Chair, but happy to take any questions.
Thank you, Gertie. Questions or perspectives, Glenn?
I've already said my bit on this, but as Gertie said, that probably the most important thing is what we do next. And we met with the individual directorates this morning, and they talked about actions. We've also, Catherine's completed the exec appraisals and objectives, and there's something in there for everyone in terms of individual objectives around this. What I'd like to see probably go to the next time we're together as a board, and obviously next time we meet, we're with the other board, so probably for our June meeting, is that just bringing together a small number of big things that we're gonna do across the organisation to tackle the issues that come out of this. As you say, the word bullying came up a little bit too much for me in the feedback, so specifically something on that one. But if we could just hone it down to a small number of things that we spend quite a bit of time board focus on and ensure happens this year.
Absolutely, will do. Thank you, Glenn.
Okay, thank you very much, Gertie. We'll move on then to the NHS England Core Standards Report for Emergency Preparedness, Resilience and Response, which we need to approve. David, thank you for joining us. Robin, are you going to introduce this?
Yeah, I can do indeed. Happy to work through the paper, and obviously I'm sure Dave will answer any detailed questions. This paper's as required for our annual update on EPRR, the core standards to the Trust Board. So in summary, we've been rated as non-compliant. That's not due to a change in practice from previous years. What has changed is the approach that's been taken by NHSE in assessing the core standards, which has impacted on all trusts in the region. And out of the 64 standards, we are partially compliant with 25 and fully compliant with 39, which gives us a compliance rate of 61%. To be substantially compliant, you would need to achieve a rating of 89%, which is 57 out of 61. Just to sort of go through a few of the actions that we've taken since then. So we've asked NHSE for an updated framework of requirements to provide future clarity on the expectations of the assessment, and that's in line with our system partners. And Dave may want to elaborate on this slightly more in a second, in terms of the Emergency Planners Group for Coventry and Warwickshire have also cross-referenced their plans with each other as well on this, because there's been an impact across the board. So we are driving development across the ICB for system level policies and plans, and that way it will then further drive more compliance for all of our organisations, and all actions that need to be taken for reassessment by the 18th of April to be compliant. We can provide a high level of confidence that the compliance will be achieved at that point, due to the fairly minor nature of the changes required on each of the points. And I'll just see if Dave wants to elaborate on any of those points further, Chair, if I may.
Of course, Dave.
Yeah, Thank you, Chair. Yeah, just to give that reassurance. So, in our opinion, there are minor details. So, for example, the EPR policy, what they wanted to see was sign off through the TMB process, whereas before we were satisfied through the Emergency Planning Steering Committee that resource commitments were addressed and discussed through that. So, there's an example of a change. In terms of business continuity, what they wanted to see, and this is why we're in partial compliance, was purchasing departments, reassurance and business continuity arrangements for suppliers. So those are the elements, which need to be included in this year's assessment. So perhaps more importantly, what are we doing about it? So we meet weekly with the Emergency Planning Action Group to consolidate, cross-review, challenge each other's plans and processes. We've asked NHS England, as Robin says, to give us a consolidated plan as to what elements they're looking for in each of those core standards. We're meeting on the 18th of April with NHS England to review our own plans. And secondly, then we've asked them for good practice across the region, which we can follow and look as a source of reference to. So again, the action plan is detailed in those against each of those standards there, and hopefully give some reassurance by the end of April, we should be certainly in a substantial region. No trust, to our knowledge, has hit the fully compliant mark. Nobody. So everybody's substantial, and everybody's suffered a reduction in their core standards compliance rating. So it is disappointing on personal and professional level, but we are adamant to get this right. And again, it's a different pair of eyes came in and assessed us, which we welcome. We're open to challenge. We're not defensive, and we're here to learn. And again, just to give that confidence in terms of learning, there's a few elements there. Training. Principles of Health Command, 19 of our 36 commanders have gone on that. It's been suspended temporarily while they get some new trainers in. That's emanating from the Manchester inquiry. Okay, so there's a big emphasis on what they call JESSA principles. So a lot of these are coming in. We've got 2 exercises to follow, one in a couple of weeks and one in May, which will again, and a lot of these compliance areas will satisfy what we're looking to achieve. So example, did we test the incident room in a major incident exercise? Sadly, no, we didn't. We tested in a different format, but that wasn't acceptable. So we can test it as part of those exercise regimes. So you're doing okay on the training, we're compliant with that, and we're on the action plan in relation to the core standards.
Okay, Dave, just before, because we need to approve this, I just want to thank you and colleagues for the work you do behind the scenes, because it's out with what we're talking about here. It's absolutely critical work, so thank you. We need to approve this, team, taking on board the comments of Robin and Dave. Any questions or perspectives, Glenn?
Personally, any observation for me is we move from a lot of greens on self-assessment to quite a few ambers on review. Is there a learning point for us around our assessment process moving forward?
If I'm being totally honest, Mr. Burley, what I would say is we've asked NHSE to give us that standard. What are these elements? There should be no surprises culture in emergency planning. So they surprised us this year, to be honest, and we said, look, okay, we did our own consolidated list. So that was a learning point from that. What was the consolidated response? Was elements which should have been in all our plans. So we did a cross-fertilization of ideas, cross-fertilization of feedback. So we got a standardized list. And secondly, do we bring people in externally to have a look? And this is what NHS England did. They brought an external person in. It was part of the, James Howden, his name was. And that was his own personal assessments on the core standards. So I think the learning is, what are the standards from an NHSE? What are we learning between us? We do consistently debriefs, not just us. So again, when we meet, we'll look at incidents across the patch. So I know, last year, without going over the top on this, Swift had an oxygen outage. They had a gas outage because they cut the pipe. They had a water outage last week. We learned from that, and we're trying to simulate those into our plans. And so we think we're doing all we can to close the gap, so to speak. So that would be my assessment of it. I don't know, Robin, if you'd like to come in on that.
Okay, we are running out of time, guys, because we've got a lot more to cover. But Robin, anything you wanted to add? Not for me, thank you, Chair. Dave, I'm very assured by the openness with which you've approached this discussion and the work. Thank you. If you're not happy to approve this self-assessment, despite the disappointments in it, please raise a digital hand. Okay, duly approved. We look forward to more green next time, Dave, as we just stop, not the own goals, but just the sort of know what we're dealing with type of approach. So thank you very much. We'll then move on to the integrated performance dashboard. So we've obviously read this. Robin, you're leading on it. What would you care to pull out?
Yeah, I think just to say February's we've seen the emergency activity continue to be a challenge, and it's a pattern replicated in all of the trusts across the UK. COVID numbers also increased in February, so putting further drain on our resources. We've already mentioned super surge and surge capacity that remained open through February, and it driven additional spend on additional staffing, and obviously in order to maintain the safety of the patient. So into high levels of bank agency spend driven, again, it's all aligned with that high levels of activity. And obviously, as we've already mentioned, coupled with the junior doctor strikes in March and the planning for April, there's a lot of challenges there for us that we've had to overcome during this period. But despite this, we saw an increase in our EAS performance marginally from 72% in January to nearly 74% in February. We're currently ranked 4th in the region. We've got a year-to-date average of 76%, which is the national ask in the emergency the new emergency standards. But again, on the basis that we know that we need to continually improve, that's not where we want to be as an organisation. And all the operational teams, the clinical teams are all also supportive of that approach, that we want to be pushing back towards 95%, not resting on the 76%. In March, we managed to close the 17 beds surge capacity I've mentioned, and we are predicting a financial break-even position, but it has taken us to deplete our resource flexibility slightly. So at the same time, it's been a strain all across the board, across all elements, and we maintained a position in the top 10 hospitals in the UK, in England, sorry, for ambulance handovers. We reduced our ambulance handover delays from 11.3% in January to 2.4% in February. We also, some other points to pull out, we also improved our diagnostic performance to 94.4%. And I think I'm right in saying that we're the only trusts in England above the 99% diagnostic trajectory now, so meeting the national standard. So again, that's absolutely a positive for us. And also we've seen a good improvement on our 2-week weight cancer performance, which was 74.9% in December to over 86% in January. And that was due to predominantly an improvement in our breast symptomatic 2-week weight performance, which was, we spoke last month, had been low in December at 44%, but in January we took that to 97.9%. So a really good turnaround and focus from the teams there, despite all of the other things going on around them. So areas for continued focus, we've got good green shoots of improvement in our theatre productivity. We saw our productivity go in January, was down in around approximately 70%, move up to 78% in February. Our cancer 62-day performance was also improved, 52% in December to 63% in January. Our ERF performance in terms of our elective activity recovery, we know there's a challenging target ahead of us for next year that we need to step up and deliver on extended targets for both recovery of our elective position and getting treatment to patients quicker and as quickly as possible, and also which will also drive improvements in our financial position. Our mortality metrics remain on an increasing trend. However, actions are in progress. We do expect to take several months to show improvements in our HSMR hospital standardised mortality ratio. So it's another key area for focus for us. Our recruitment, we continue to focus on speeding up end-to-end recruitment processes. It's also been mentioned. So overall, we've got to focus on efficiency and delivery of efficient ways of working that progress us back towards those national standards that we still strive to achieve. And again, I'll pause there.
Thanks, Robin. And first of all, just to say, in terms of the finances, great performance team to deliver break even. Questions and perspectives, colleagues. Glenn?
Just want to say well done on 78 weeks, because that's a really important milestone in the recovery of the NHS, and quite a few trusts around us did not deliver that. In fact, ended up with quite a few patients who who were not treated within 78 weeks. So it's a well done for achieving it and for helping some others along the way on that. So I know, Leicester improved their performance significantly, and we provided mutual aid to them. So that's really good. And the other one, just to get on my soapbox, if I may, Chair, for a small item, our diagnostic performance is fantastic. Yet in the national single operating framework, we don't do well on it, because what that looks at is our historical level of diagnostic activity compared to today's diagnostic activity. It takes no account of access times. So I've booked myself in for a little chat with the national lead on that to try and understand why they're coming at it from that lens, because we should be the best performing rather than getting a fail, because and that's simply because we've historically done high levels of activity, particularly our endoscopy activity, and we shouldn't be penalised for always being productive. So I'll report back to the board when I've had that chat.
Thank you, Glenn. And any other questions or perspectives to Robin? Okay, team, keep up the good work. We'll talk about what next year's finances are looking like, and how we drive that waiting list down even further to get down to 52 weeks as quickly as possible. So we'll move on then to the Capital Q4 report. Hack.
Thank you, Chair. I'll just draw out the key points. So we've got a capital programme of just under £13 million, and the biggest project within that is the CDC Phase 2, currently under construction. So that's £7.7 million this year, but a total of £10 million on that project. Now that was originally we were expecting to use some of our own funding towards that, but we did get that fully funded, the full £10 million funded through the national funding route. So there's a number of kind of implications of that. Firstly, it means that they wanted us to spend more money this year than we originally planned. So that means we've had to order the MRI and CT scanners in advance. It also means that we were originally looking to use some of our own business as usual capital towards the CDC, but we don't have to do that now. But so that means we had more capital available to spend for ourselves than we originally expected. And we also had late notification of the CDC funding, which is why we've got so much expenditure still left in the final month of the year. So it's largely around late notification of the CDC funding, and the fact the CDC is a big project in itself as well. But we're confident we can spend all the money this year, even though half the capital programme is still to go in the previous month, but vast majority of those projects are well advanced. The other area I wanted to pull out was maternity theatres that you've already heard mentioned by Lorraine. So the 2 maternity theatres are being refurbished at the moment. That's another project that will cross financial years, and it's a fairly big project. That's why I pulled that one out, but also it means it gives maternity 2 fully functioning theatres as well. The final point I wanted to raise was about next year's capital programme. We haven't agreed the allocations, but we are asking for a significantly larger share of the systems pot. That's because there's a number of projects that we want to do, but also we want payback really for where we've underwritten the systems capital programme over the last 3 years. So the projects that we really want to do are sorting out our car parking, because we've built on a lot of our car parks. The CDC Phase 2, we want to kit out some of the white space we're building as part of that. So breast service get a fit for purpose space within the CDC. And the third element, again, you've heard about it this morning, I think, from the directors around mortuary, around realigning the capacity for mortuary. So 3 fairly big projects that we want to do. So it's not that we're asking the money for no reason. They're all important projects that we need funding, but also we have supported the system previously, so we're asking for that support back now going forwards. That hasn't been agreed as yet, so we're still negotiating on that. So in summary, as with previous years, we've been successful, I think, in getting significant additional funding into the trust. I just wanted to thank the estates team, the directors and the finance team for managing to spend all that money in a short space of time and delivering on the projects. And finally, looking forwards, we continue to strive to maximise our capital funding and and make sure that we've got fit for purpose estate and the state-of-the-art technology as well to support the services. I'll leave it there, take any questions.
Well done, Hack. As a general principle, encouraging people to spend money at pace is not something I'm entirely comfortable with, but I take the essence of what you're saying, Hack. Questions and perspectives to Hack? Okay, team, thank you. So we'll move on then to the annual review of standing orders, standing financial instructions and scheme of delegation, and this is for approval. Sarah.
Thank you. So the proposed amendments are shown as track changes and they have been considered by Trust Management Board and Audit Committee. So it's for the board's approval. Hack, did you want to add anything specific?
And just, I think, a general comment really that there aren't significant changes to the standing financial instructions or scheme of delegation, because we did a big piece of work on it last year to align it across the group. So there's some minor tweaks and some refinements reflecting some of the learning actually of using the new standing financial instructions over the past year really. So nothing significant, but just a few refinements just set out in the covering paper.
Okay, super. Classic example of things that can go into an appendix for the future team. Any questions or perspectives on the annual review of standing orders, standing financial instructions and scheme of delegation? If you're not happy to approve, please raise the digital hand. Okay, super, thank you. And Sarah, you've also kindly been doing the annual review of Register of Directors' Interests. Over to you again.
Thank you. So this is the updated register which will be captured in the Trust's annual report. Julie Holder has submitted a change. She's no longer chair of the Sir Josiah Mason Trust. And I can see that Hack's got his hand up. I don't know if you want to add anything, Hack.
I wasn't sure whether to do this at the beginning of the meeting or now, so I'll do it now. I recognise, Chair, that there's probably something I should have declared previously. It was a partnership in a coffee shop that no longer exists, but I probably should have declared it sooner.
Okay, Hack, thank you. If we can just note the details of that in the minutes, that would be good. Just a general point to colleagues, anything that you're involved in or a partner or loved one is involved in, I suggest you put in the declaration of interest. For example, I put in the fact my son works for Deloitte, even though it's not in the accountant part, never does anything involved with us. I would just be totally open so that no one could accuse us in the future. And that includes if you're a clinician and you do private sector work. I would like that declared. Thank you. Any other questions on the Register of Directors' Interests? So duly noted. Sarah, I did notice in Integrated Care Partnership meeting I was in, when it talked about my declarations of interest, it didn't have all of them. And I know the list you've got here is the same list that I have at Swift and I have at Wye Valley. Can you just make sure that goes up to the Integrated Care Partnership, because they just seem to be doing my NHS stuff, and I've always been very open about everything. Okay, team, thank you. So we'll move on into the annual fit and proper persons declaration, again with you, Sarah.
Thank you, Russell. Just to confirm that all board members voting and non-voting have recently done their annual fit and proper person declaration. So this report is to be formally received and noted. Thank you. Okay, super. All fit and proper. I always find that quite intriguing. So we'll move on then to, so we just note that. The annual board self-certification G6 license condition. Back with you, Sarah. Thank you, Russell. So this report and the next report, they are both for the board to consider and certify against each statement. Since I've submitted these reports, a new provider licence has been published with effect from the 1st of April. and the board self-certification requirements for this report and the next one have been removed from the final modified licence. The self-certifications do keep the board's focus on compliance and governance processes. However, the decision to remove the reporting requirements has been made to streamline requirements and reduce burden. It's recognised that there's a range of other reporting mechanisms that would continue, such as the annual report, annual governance statement, and through the CQC well-led reviews. So these require boards to continue to assess their compliance and corporate governance standards, and evidence of the compliance will continue to be considered as part of the well-led assessments. So I'd therefore like to invite the board to consider whether or not to continue with these annual board self-certifications for future years. And Russell, based on your earlier comment about reducing the board pack, I'd recommend that we perhaps remove these, as there is going to be compliance in other areas.
Okay, apologies, Sarah. I didn't know you were going to say that. So what I'm about to say, I apologise for. I find it slightly strange that we're no longer being asked to self-certify our G6 license. I'm used in other places to certifying the G6 license, and I understand it's occurring in other places, but this isn't a terribly burdensome bit of the board pack. But in my view, it is quite a good discipline. So can I ask Sarah for us to come back on the point you've just made, and you and I to have a chat, maybe with Glenn, but let's just focus on signing off this one rather than making the longer term decision. I think it's quite a good discipline for the board to say, no, we think we are fully compliant with the provider license. And I'm used to doing that in different areas. But out with that decision, just focusing on this annual board self-certification. Questions and perspectives on the G6 license, first of all, Glenn?
Yeah, I'm with you, Russell. I think it's good practice to ensure that we are compliant. So I think there's just a choice for us here about whether we do this at board or whether we do it through audit committee, but I think we should continue to have a mechanism. Yeah.
And I'm very happy for it to be an audit, but let's just the three of us take it away. If any colleagues have got a view on that, please don't hesitate to reach out to me. So any questions and perspectives on the G6 license, first of all? So we'll move on then to the corporate governance statements, FT4. Sounds like a branch of special branch, or something from the professionals back in the 80s. I've worked for FT4. So any questions on FT4, the corporate governance statements? Okay, so we duly receive and note those. I'm showing my age. I apologise, gentlemen. The summary of ratified policies. Robin?
Yeah, so the policy review group met on 24th of February, continues to ensure that there's robust scrutiny and process monitoring of approval of trust policies in place. There were two policies discussed as detailed in the Appendix A of the report. One was the data protection impact assessment policy, and the other was the subject access request for personal records policy that some people may have formerly known as the access to health records policy. Both policies were approved. Details in the paper of the minor amendments made to the first of those policies, the DPIA, around the data sharing agreements. Both policies were approved, and nothing else to add.
Thank you, Robin. Any questions on the summary of ratified policies, just for receiving and noting? Okay, thank you. And just for members of the public, we may not know the answer to this, but on the NHS app, it says you can gain access to your medical records. Does that include all of your acute medical records? I don't think it does, but if, sorry, Sarah's gesticulating at me with passion.
I was just going to say, I know that I have patients who can access their hospital letters very easily, multidisciplinary team real-time letters, but anything that's still handwritten in hospitals then clearly isn't available yet, because it's not it's still there in a written form rather than an electronic form.
Yeah, I think it's misleading is the point I'm making, and I think you're confirming that. Okay, thank you very much, Robin. So we'll move on then to the board assurance framework for the final report, I think, for this year. Robin, over to you again.
Okay, thank you, Chair. So I take the report as read. Executive leads have completed a review of their respective risks on the board assurance framework for Q4 in line with corporate risk register and the trust objectives. Key areas to note that in the report, all changes are still marked in red for ease of reference for those on the board reading the report. There's no change to the level of risk appetite. There's only one risk that's increased from a score of 12 to 16, and that relates back to the capital expenditure, and that has already been mentioned by Hack in his earlier report. That raise in risk because the lack of assurance around the capital allocations for remaining for next year. So that's the underlying reason for that small increase in risk there. This report has already been seen by Anil as the FPE lead NED on scrutiny, and has also gone through the exec risk committee where it was approved, and also through quality assurance committee where it was approved.
Okay, thank you very much, Robin. Any questions or perspective on the BAF? It's not so much a BAF issue, but it's more a risk register issue. For me, one of the big things that we've noticed or had to cope with over the last year are nurse and doctor strikes. Can we just make sure that they've got a high enough profile on the risk register? Because certainly if you take the last 5 years, they wouldn't, if they were on a risk register, they'd be minimal, whereas we know that the last year they have occurred, and certainly, as Graham was talking about in his board report, are having significant operational and therefore patient safety consequences. So can we just make sure the risk of frontline staff going on strike is being properly risk assessed? I'm sure operationally it is, but whether it's on the risk register. Robin?
Yeah, I'm certain it is, but I will I'll take that action to revisit that with Claire Hayward.
Okay, thank you. And Gertie?
It's just to confirm, Chair, that it is on the risk register. I can't quite recall to mind what the risk score we've given it is, but we did increase it when we had confirmation that the BMA had voted for strike action, as we had previously been unaffected by the RCN strike. So I can confirm it is there, and I'll look with Robin on the scoring to ensure it reflects the impact.
Okay, super. Thank you, Gertie. And finally, Sarah, then we'll move on.
It's just a reflection for me as a non-executive, again, that I do think that the board assurance framework, some of the language there and the way we articulate the things that we want to be assured of and our risks is really positive and reflects the culture of the organisation that we are and that we want to be, with reference to patients, with the culture that we want our staff to work in. And I think it's just really important we reflect that in the decisions we make and how we act. So thank you for the people that have put that together and articulated it.
Sarah? Okay, colleagues, happy to move on to the use of the trust seal. Sarah?
Thanks, Russell. So this just outlines the contracts and documents that have been sealed through the financial year for the board to receive and note.
Hack's been busy with that seal, stamping away in his corner office. Any questions or perspectives on the use of the trust seal? Okay, super. So we'll just receive and note that. So we now go on to the annual review of board committee terms of reference. Sarah?
Thanks, Russell. So all committees have considered their terms of reference, and the proposed amendments are shown as track changes, ready for the board's approval and ratification. Thank you.
Pretty minor, the changes, I think it's fair to say, isn't it? So
they are.
Any questions on those? We need to approve these teams, and I assume all of the chairs of the subcommittees have been through the relevant terms of reference. If you're not happy to accept those revised terms of reference, please raise a digital hand. Can't see any digital hands raised, so thank you. They're duly approved. Thank you, Sarah.
Thank you.
Then the annual review of policy review group terms of reference. Robin?
Yeah, in the same vein, really, that this was reviewed at the exec policy review group on the 24th of February. No changes other than a format change to the template. So request board to approve.
Thank you, Robin. Any questions or perspectives on those? If you're not happy to approve, please raise a digital hand. Duly approved, thank you. And then we've got some annual reports just to receive and note. The first is the Audit Committee annual report and annual objectives for the year ahead. In Julie's absence, Hack.
I'll just draw out a few key points. So overall, the committee's functioned effectively with good attendance. The audit plans are on track and the audit recommendations are followed through in a timely manner. About a year ago, we implemented post-audit reviews, which involves officers coming along to the committee and reporting back on the changes and improvements they've made as a result of a previous audit. We found that really helpful. It leads to much richer conversations than you'd have just from getting written updates on the audit recommendations. And both sets of auditors have commended us on that approach. So they don't see that in the other organisations that they audit. So that's got some good practice there. The key area the committee would like to focus on moving forwards is governance arrangements below board level, but you can see the other objectives as well that we've set out. We haven't finally agreed these, but you can see the kind of the lines where we're going down with that. So those are the only things I really wanted to draw out. So I'll take any questions.
Thank you very much. Any questions or perspectives on the Audit Committee annual report and their annual objectives for the year ahead? Okay, super. And thank you, Julie, and everyone involved in the Audit Committee. Your hard work is greatly appreciated. So we'll move on then just to receive and note some subcommittee chair updates. The first is the Quality Assurance Committee from the report from the 28th of February, the verbal update of the last meeting of last week, I think. Sarah?
Yeah, thank you. So you can see the update that we've provided there, and then hopefully the appended minutes of the meeting that we had last week. Most things have been drawn through already, especially we give a lot of focus to the things that are there in the maternity and the nursing assurance reports, and so do go through that in significant more detail, and the staffing as well. So I think it's just to bring those items to your notice. Again, really positive that we are developing. I think I mentioned this before. We're developing two things: the reports, as you mentioned, Russell, and streamlining those and really highlighting through the things that are pertinent to assurers of quality and safety. But also, we're looking at a way of developing our assurance framework so that we can be really clear on what we're being assured about and the level of assurance. So we're just tweaking some of the language and the way that we report that through. But that's all. Thank you.
So any questions or perspectives to Sarah? Sarah, one of the things I'm picking up from patients and their families in South Warwickshire is an anxiety about the cancer turnaround times, and in particular the way the pathway works between ourselves and UHCW. Can I just ask the Quality Assurance Committee to have a particular look into that to see whether our patients are similarly suffering from pathways not working quite as they're intended to? Thank you.
Yeah.
Then moving on, and Simon, thank you for taking over nobly the chair of the Audit Committee. Your report from the week before last, please.
Thanks, Russell. It's actually Julie's report. She chaired the meeting and she's produced her usual comprehensive report. The meeting, as always, generated a lot of open and honest discussion, and I would hope that as the incoming chair I'm able to continue to generate that kind of spirit in the meeting, and I would like to put on record to Julie my thanks for the care and attention that she's shown in the handover process. Thank you, Chair.
Thank you, Simon. Any questions to Simon on behalf of Julie for those minutes? A nice thumbs up from Umar. Okie dokie. Then the improvement board of the 21st of March. Glenn, anything you'd like to add?
Nothing to add to the report, thanks, Chairman.
Any questions or perspectives to Glenn on the improvement board? We've got our quality, our CUSA away day coming up, I think, Glenn, next month. So that's something that will be great to get feedback to the board after that's occurred, which is a cross foundation group day of sharing some really exciting projects that have been worked on and improvement generally. We'll move on then to the Foundation Group Strategy Subcommittee from the 28th of February, which we will take as read from Julie, but any questions or perspectives on that? Glenn?
Yes, so as you previously trailed, if you see under item 5 there, the virtual event actually is over 4 days. And will bring together examples of good practice from across the group. So between the 15th and 19th of May. So we're looking forward to that event kicking off.
Okay, great, super, thank you. So then just in terms of the Quality Assurance Committee of the 28th of Feb, anything you wanted to add to that, Sarah?
No, thank you.
Super. Or the Audit Committee of the 17th of January. Simon, anything you wanted to add to that?
No, nothing. Thank you, Chair.
Okay, super. So I think then we're on to any other business before I go to questions from members of the public. Any other business from board colleagues? So, members of the public, lovely to have so many of you with us today, but would any of you like to ask a question? I'm not aware, Sarah, of any questions having been raised beforehand, but if you've got a question, now's your opportunity. So, Natalie.
Oh, good afternoon. Thanks to Robin for such a comprehensive report around where we are with diagnostics and elective, but I think members of the public are quite anxious where we are with the junior doctor strikes and appointments being cancelled and operations being cancelled. Is there any assurance that you can give the public around that?
I think things, just before I invite Robin to come in, things are obviously very difficult, Natalie, with us losing so many members of staff. And as Glenn said, for an extended period of time across a holiday period for a number of our consultants. But Robin?
Yeah, if I may, Chair, just to be clear, so thanks, Natalie, for the question. And obviously, it's something that is really taking up a considerable amount of our time in terms of the planning and preparation for the next week, but also it took a considerable amount of time in March. And obviously, the work we do starts on the basis that we really try not to affect anybody's care. And so first and foremost, we protect our emergency services and our cancer services, and therefore we try to minimise any further disruption. So if I may, just during the March activity, the industrial action period, we actually rescheduled 420 outpatient appointments, which in context was about 18% of our overall outpatient activity. So by virtue of that, 82% of our activity continued as scheduled. Likewise, with day cases, we only impact on 43 day cases, which was 21% of our activity. But again, 79% of patients were unaffected through the planning that we did. Particularly proud of our protection of our elective activity, our elective inpatients. We only had to reschedule 2 patients in total, which again was down to the hard work and the planning by the clinical and operational teams involved, and we regrettably had a couple of 2-week wait clinics that had to be cancelled and rescheduled, and there were 31 patients affected there, which was 15% of our scheduled activity. So again, we protected 85% of the patients going through those services, and through the actions that were taken. And I can say all of those patients have been seen since and have all gone through their onward journey through their pathways. So again, we will continue for the strikes for next week in order to maintain the same principles of minimising the impact to patient care. But I think, as Russell and Glenn have already said today, it's inevitable that there will be some impact, but we'll try and minimise that.
Thank you, that's reassuring. Just on another note, David and I did actually go and visit some patients that were in surge beds in the Captain Tom Moore unit, and while we were there we asked them about the last junior doctor strike, and they said that they hadn't noticed any difference to the care that they've been given. So I think that's quite reassuring. Thank you.
Thanks, Natalie. But just in terms of managing expectations, I think the combination of the Easter holidays, when a lot of our consultants take holidays, plus that then 4-day week and then the other bank holiday, I think is very likely to cause more disruption than the last junior doctors strike. But again, just reiterating what I said earlier, I can't thank our consultants enough for the agility and flexibility they've shown in being trying to help our patients and citizens during this difficult period. Any other questions from members of the public? Otherwise, I'll draw us to a close. Well, our next meeting is on the 6th of June, sorry, the 6th of May. So I look forward to seeing you all then. Actually, at the end of the agenda, so it does say the 6th of June, which is confusing me a little bit, Sarah Colette.
That's right, Russell, because it's the Foundation Group Boards, the next one.
Thank you very much. So I look forward to seeing members of the public at the 3 board meeting, hopefully in May, and then the next George Eliot board on the 6th of June. So apologies for my confusion. And Glenn, is there anything you wanted to say in close?
I was just going to say, technically, you're both right, because of course it is a meeting of George Eliot board. It just happens to be in parallel with the other trusts in the group. So it's not a 3 boards meeting. It is a meeting of George Eliot board with the other 2 boards having their meetings at the same time.
See, that's why Glenn Burley was voted as one of the top 10 chief executives in the NHS, because not only does he manage to operationally and strategically run the organisations, he knows how to bail his chairman out when he says something which is potentially a little bit misleading. Look forward to seeing you hopefully at the 3 board meeting in May, and then our own board meeting in June. Take care, everyone, and look after yourselves, and happy Easter. To my board colleagues, we'll have a 10-minute comfort break, get together again at 3:45 for the confidential board. Thank you.